First and foremost, I want to thank the Anterior Hip Foundation for the opportunity to be invited to the Shark Tank. We're looking forward to this. I know it's getting a little late. We're going to make it fun. We're going to make it informative. So let's get started here. Here's my click. Okay, so I get asked a lot, so Steve, how in the world did you come up with this idea? And it's a culmination of 30 years in orthopedics as an industry, both as a rep, as a distributor, and ultimately I did some product development with a couple of gems, Larry Dorr and Aaron Hoffman, who taught me a lot about product development and just ins and outs of good instrumentation. So I was blessed to have that experience. So, watching really observation. So 30 years of observing surgeons, I learned that, we as reps, we as industry partners, best thing we can do is observe what you're doing and try to make you better at what you're doing and help you out. So these minimally invasive, disruptive, non-disruptive tissue, soft tissue procedures, we're building ships, you all are building a ship in a bottle, and you get this ship perfectly done, some great surgical pioneers with these techniques. You're able to get this ship put together in a bottle, but then you got to break it apart when you go to retrial at different length, different head size. So I thought to myself, there's got to be an easier way. So I got with my engineer, who was also worked with me with Drs. Hoffman and Dorr, and Jay is a brilliant guy, and I said, hey, there's got to be a better way. We've got to be able to do this in situ and not be able to have to just rip this thing back and forth. And he said, all right, it's going to be difficult, but I'll think about it, and he got it done. He called me a couple weeks later, he said, I've got it. So we came out with version 1, which worked very well for posterior approaches, superpath type approaches, and clinically it was answering a need for some surgeons, but we had to think, what are we missing? Who are we missing? And of course, we got some reaction from some of our anterior surgeons saying, love the concept, love what you're doing here, but we really need a better access to this anteriorly. It's difficult to get to the original drive. So we started working on an offset drive, and we accomplished that with the version 2 of the HipTurn, which is gone over so well that we decided that we would go to AUKUS in November of last year just to see what kind of reaction we would get from the surgeons. And it was overwhelming, the response. We got a lot of traffic in the booth. Dr. Schwarz came over. He was extremely excited about it, so we decided we would try to get him to bring him in to help us from the surgeon standpoint to kind of guide us. And so we put together, we decided there's a big need here for this product to get this to market. We kept getting asked at surgeons, even at this meeting, when's this going to be available? When's it going to be available? So we put this team together. We realized this is going to be a good thing. So we put the band together, and that's our team right there. You see 3 of us, Jay, David, and myself, and then we've got a regulatory guru who's been consulting with us now for 6 months, and then we've got a couple of surgeon advisors. So we're off to the races. I'm going to hand it over to my colleague David here. He's the detail guy. He's the smart one, so I'll let him answer these.
What is the HipTurn? It's more than just an adjustable femoral head trial. It's an in-situ hip tensioner. Our current offering is 36 millimeters, fits on a 12-14 taper, 3.5 millimeter increments. Ongoing forward, we'll have a 32, we'll have a 40, we'll have a dual mobility option, and even a hip fracture option. With market demand, we will put it on other tapers, and as well as have additional lengths. How does it work?
After insertion into the joint, simply rotate the gear turn handle clockwise to lengthen and tension, then counterclockwise to reduce tension prior to final dislocation and removal of the hip turn trial. This simple process is designed to achieve the correct length efficiently in a single reduction.
HipTurn is not going to supplant technology, it's going to enhance technology. All the technologies on the screen are here today. Let's go straight to imageless navigation and robotics. You drop your HipTurn in the short location, you see your data on the screen, and with simply a turn of the screwdriver, in real time you can visualize your leg length and offset optimized for your patient. What about image-based AI, this open platform? Bring your x-ray in, never move it, see your leg length change with each shot. In 30 seconds, you get 4 data points, and you can have the right solution for your patient. In the previous generation, there's a little posterior approach showing you can get the x-ray shots without adjusting the pelvis, just like that. There's some volume, but it may not be coming through. All right, I'll just skip forward. There was the JAWS background there. Oh, there it is. All right, so what the sharks want to know is they want to know the market analysis. Data says there's over 600,000 hip procedures done every year in the United States. All of them use a trial head. And our market research shows us that in a disposable form, that hospitals are willing to pay $200 to $400 for this. That represents a $100 to $200 million market as a disposable head trial. Over half the hips are 12-14 tapers according to AAHCAS data, which means we can work today on over half the stems in the world. And if we capture a small portion of that model, it's a great business for us. I'm going to turn it over to Dr. Schwarz.
Thanks, David. So thanks, y'all. I'm Andy Schwarz to offer a little clinical perspective on this bright idea. So I think we became anterior zealots in part because of the accuracy and precision of this approach. So for patients like this former joint replacement surgeon who made me drag over the portable x-ray machine and pack you so he could see his post-op films, I think accuracy is pretty important. Although I think most patients would agree about that as well, as leg length discrepancy still remains one of the most top litigated claims after hip replacement. However, I think as anterior approach has matured, it has also become synonymous with efficient, and I think we all know that the arduous process of trialing is not necessarily commensurate with efficiency. So while I agree with Chevy Chase that it was my understanding that there would be no math, I think we are often making rough estimates doing addition, subtraction, and trigonometry in an effort to avoid that dreaded retrial. Now, I think in this master class of anterior approach, which we've seen a lot of today, we do some pretty badass cases, but to be honest, for cases like this, I'm about as interested in going through an arduous trialing process and testing my cup fixation as I need another hole in my head. And then my last point is, when are we going to get over these kind of geriatric trial heads that we've been using forever that may or may not be in the tray like they're supposed to be and delaminate green, blue, orange particles into the hip joint space? And this kind of crazy case report actually led to recurrent instability and catastrophic third body wear. So kudos to Steve, David, for coming up with a better idea to make us more accurate, more efficient, and safer.
Thank you, Dr. Schwartz. All right, so we're going to wrap it up here. What's next? We've got a meeting coming up with the FDA. We feel we've gotten some good feedback that we feel really certain that this is going to be a Class 1 device, and we're going to hit the green button, and we're going to get going. So let's do some questions.
So I'll go. Thank you for the presentation. So you described this as an in-situ tensioner, which is actually really cool. And sort of what that suggests is you can fine-tune sort of what's happening when you're trialing without switching heads out, right? So presumably that gives us some sort of like more accuracy, some sort of presumable benefit on outcomes as well, while in theory reducing time and potentially getting rid of head trials in the set. So what are your views about like how much of this is driving improved outcomes with that fine-tuning you get with the tensioning that it creates, and then how much of cost saving are you driving with just with time and bits in the set?
We get asked that all a lot, and kind of working with industry, you know, they like the reduction of the inventory, and that's fine, but that's not really what this is all about. This is about helping you as a surgeon with your accuracy. To David's point, we're not trying to supplant the technology. There's lots of great technology out there, but this is a simple, practical way to get something in your hand so you can feel that, and you don't have to take your eye off of it as you do this. It's going to help with your efficiency in the OR. It's going to cut costs. It's going to improve the efficiency and patient safety as well for the hospital.
If selling a new product into the same DRG is challenging to begin with, and I have to choose now between HipCloud, tracking all the interactions with the patient, modular disposable reamer head and sizer, or a disposable tensioner, how do I choose which $200 to spend?
Well, you spend it on us because we're going to give you a tool that's going to, once again, the theme of the meeting, we want to be disruptive. We want to advance anterior hip surgery, and we can do all of that, but we do have to go to the hospitals to partner with us. I am also, my day job as a distributor, I've been in the business for 30 years, a distributor for 20. I understand the dynamics of the hospital. Hospitals will pay for disposables as long as there's a surgeon that has, a reasonable plight for why they want to use it, and they can show, like, if we can save you 10 minutes per case and you're doing just 5 hips a day, that's an extra case that the hospital can get done. And we can talk about the safety of not having to use these reusable trials, because these things, talk to your reps, these things get beat up, they get scarred. You're putting a trial that's been used maybe 100, several hundred times into your brand new acetabular cup and liner. It could scratch it. I mean, these things fall apart. We're going to save you time, and we're going to save the hospital money through giving you, we're going to give the hospital an opportunity to give you an extra case per day, we think.
Is it time and money, or is it the beauty of being able to tension inside too?
I mean, for you as a surgeon, being able to get, feel that tension inside too, and not have to rip apart that beautiful ship you built in the bottle. And then as you saw on that x-ray, you're looking at x-ray that the pelvis never moves, but your offset does, and it's right there. And I even had a surgeon one time say that they would dictate that in their op note, that they actually visualize that.
I would say between the Reamer expander and HipTurn, we have a fully modular acetabular portfolio. So
Yeah.
you guys should talk to each other. I think my question is more around, again, I would say in our experience, hospitals hate paying for consumables. Do you see this, again, solving a big enough problem that it'll be used in every case, or will surgeons pick and choose so that your TAM is actually much smaller than what you think it is?
This makes the most sense if you don't change the workflow for either the rep or the surgeon. So you go in your case, you put in a 52 shell, you open your realigner, because almost nobody's using trial liners, especially on the anterior approach. You open your hip turn, and you go away. So every case. The disposable business models don't work, in my opinion, long term, if you only use it when you need it. So it is something that will get used every case. And at the end of the case, you want to hit the easy button, and this allows the surgeon to hit the easy button. And there's some reps here, and I think they would agree with us, is it really is a lifestyle help for the rep, because how many hours do reps spend every year looking for lost femoral head trials? So from a sales perspective, the reps will be motivated to go out and sell this.
I would add, when I've talked to surgeons about this, one of the most interesting responses that I heard is actually reps overhearing me talking to surgeons about it, and then me learning how much time reps spend filling trays to make sure that there's a full set of trials that aren't broken, damaged, sterilizable, and incomplete. And so I think it really helps quite a few different parties and identifies something that we've kind of assessed as a problem that can't be fixed and making it a fixable problem.
But to that point, though, right? There's lots of other stuff in the trays that are small that, so this attacks a small piece out of the 6 trays, unfortunately, that we bring in. Is a bigger 6-tray problem, quite honestly. But it's a convenience, right? I mean, it's hard to extrapolate this since you got the options in the tray. They're a little more manual, a little more laborious, right? A little more time consuming. But the reality is it's convenience, right? So because we're not going to be able to extract it and directly correlate it to a clinical outcome, therefore, it's a cost factor, and I'm surprised based on a company that sells lots of saw blades, lots of disposables and hips and knees, lots of drill bits and burrs, that the price point range that you gave for the average selling price, I think is an extraordinary range. We try every day to get even close to that, and I got to tell you, in the masses we don't, and we got some very aggressive sales guys. I love your tie, by the way. Is that really the hip turn on your tie? Yeah, that's good. So you're a sales guy. That's why you're in sales and we're not. But you know what I'm saying? I mean, the cost range for your modeling, and I'd wonder where your cost of goods and your cost of goods with margins may be forcing you to go to that price point.
It's a great question, and the one we get asked all the time. I think where the rubber hits the road on this is that we ask surgeons that own their own ASCs, what would you pay for this? And those surgeons said, this is going to save me a lot of time. It's going to be more efficient, more safe for the patient, at least a couple $100 out of my own pocket. This is what